Okay, so the recording has just started now. Okay, so the first speaker of the day we have is Dr. Abhishek Ashok. He's a brilliant trainee. I know him for a long time, and he's an academic trainee currently in Cambridge. He was rank 1 for academic trainee posts in Cambridge during his time of recruitment, and it would be brilliant to have his insight as to how he prepared for the post. What does he think about radiology recruitment, and how to prepare for the interview? All right, over to you, Abhishek.
Thank you, Asim. Thank you for organizing. Thank you for coming to this session. First, I'll share my screen. Okay, so I'm going to talk about radiology training and the interview process briefly. So as you all know, radiology training is sort of run through for 5 years. And if you choose to do intervention, either body or neuro intervention, there will be an additional year, ST6 year. So I would highly recommend you to sort of have a look at the RCR radiology specialty training curriculum, which talks about all the requirement for the training. And it would be good to be familiar with all the content. So if there are any relevant issues which come up in the interview, you will be in a position to sort of explain it in a better way. So general expectation is that in the first 3 years, you are familiar with core radiology, including plain film, ultrasound, CT reporting, acute reporting, and then a bit of MR experience. And then in the special interest year, obviously you will have more time to do whichever MSK, neuro, whichever you choose to do. But of course, you need to maintain core competencies. General split is 20% core and 80% specialist interest training, but it varies quite widely. Moving on to next slide. So the first thing is to sort of know what day of a registrar look like and what a day of consultant look like. Obviously, most of you would have done taste a week. But some of you may not have opportunity to do it because of the COVID. But general day will involve either ultrasound, plain film reporting, fluoro, CT list, MR session, along with some level of duty or protocoling, and also a teaching session. So it will vary depending on which rotation you're in. And each training program is quite different in terms of when you are expected to be independent. For example, in our training program, they expect us to be independent in ultrasound in 6 months to a year. And of course, there will be supervision all the time. If you're unsure about anything, you can ask. Similarly, fluoro, you're expected to acquire the images, discuss with consultants. So there will be a very good level of supervision throughout, but depending on how you're doing, you will be given independence. So a day in clinical radiologist will obviously involve patient outcome measures, patient safety measures, and service improvement. So that include diagnostic reporting, intervention, MDT meeting, and troubleshooting with respect to acquiring images, or if there is anything that needs a consultant input. Obviously, protocoling is quite an important aspect of it. And if there are any issues with radiation protection, they will be involved to varying degree. And of course, teaching, research, quality improvement, management, depending on their interest. So let's move to interview, what they expect you to sort of know. So first, they want to generally understand whether you have an overview of what a career in radiology will involve, and whether you are committed to this specialty. And of course, by asking you different questions, they will be assessing your communication skills, and they will throw some questions at you like any other interview. And see how you respond, which is a sort of indirect indicator of your ability to work under pressure. So most important thing is to do a taster week, because if you haven't done that, how are you sure that you will do the job for rest of the year? So you should have what the current NHS um, radiology will involve. So they are highly looking at this during the portfolio assessment or in your interview. And if you are answering any questions, obviously you can bring your experience um, in terms of what you saw when you were doing taster week. That looks generally quite good. And they're looking for objective evidence. For example, if they ask you, are you a good team player? You can say, yes, I'm a good team player. But what would make it a slightly better answer is if you can show an evidence, as evidenced in my multi-source feedback, I have been a good team player. So this applies to everything. So it's not particularly for radiology. I think it's any interview, they're looking for objective evidence. Although you have provided in the portfolio station, it would be good to say it out when there is opportunity. And the other thing is to know the current hot topics in radiology. That's because it shows you that you're interested in radiology. You know what is happening, what are all the challenges, how people are trying to mitigate it, and what might change over the years. So those topics will include skill mix, artificial intelligence, radiology workforce, teleradiology, and 7 days NHS. So I'm going to go into a bit more detail of all these topics briefly. Obviously, I can't cover in the short time. And also other issues in radiology, for example, learning from discrepancies, MDTs, FRCR exams, and academies versus traditional training. One major issue here is imaging volume. So this graph shows how imaging is increasing over the year. So plain radiograph, more or less, it's the same over the past 5-6 years. But if we look at the CT, from 3.3 million studies to in 2012, 2013 to, it has increased to 5.1, which is nearly 50% increase. Similarly, MR examinations have increased from 2.3% to 3.5%. So this will sort of show how radiology is quite important in clinical decision making. It will also say the pressure, and it says a lot about workforce planning and outsourcing and all the aspects. So it would be good to have a sort of idea about these current issues which is faced by most radiology departments. Moving on to skill mix. So this is essentially a sort of image interpretation or involvement of non-clinical radiology healthcare professionals. They can be reporting radiographers, cardiologists interpreting cardiac CT, MR, and various other professionals. So as with anything in life, there will be positive and negative aspect to it. So it will be sort of integrated, streamlined service. If clinicians are interpreting, they may have a clinical information and more information from other aspects of their care. And in terms of reporting radiographers, a lot of research has shown that it helps with the job satisfaction. People would like a role development, career progression, as in all fields. Of course, there are some negative aspects to it. So if people are not adequately trained enough, it can lead to error, and then that can have medical legal consequences. And multi-system imaging, obviously they will be trying to do certain things, and if there are incidental findings in other aspect, for example, if someone is sort of trying to do CT urogram, and if they miss a liver met, there will be a huge consequence to it. So any image interpretation would require breadth of experience. So the question is, do we have enough opportunity to train them, and the resources required for that? And of course, there will be loss of training opportunity for everyone. So these are all current challenges. And then we'll move on to the next topic, which is artificial intelligence. Obviously, everyone would have heard, and whenever you say, I want to be a radiologist, someone will say, you will be replaced by AI. But then you need to understand a bit more of it. Um, so clinical radiology workflow will involve scheduling, acquisition, pre-processing of the image, and then interpretation, reporting, and putting everything together as sort of seen in this diagram. So artificial intelligence will sort of, obviously main focus is for abnormality detection and sort of segmenting it and classifying it as whether it's disease present or not, and putting it together for a staging purpose, and also to monitor change, for example, after radiotherapy or chemotherapy. So this is the main aspect, but there are lots of aspects to it. In traditional AI will involve machine learning aspects such as texture analysis, shape analysis, and things like that, but more advanced or deep learning algorithms which detect a more subtle, deep hidden features. So they may be able to detect things in a better way. But lots of research is going on. Not many things have come into clinical practice. But it will eventually. But what we also need to sort of think is it helps us for many non-interpretive interpretive uses, such as noise reduction, automated sort of assessment of image quality, decreasing the scan time, helping with scheduling, prioritizing, and then sort of helping with protocol selections. So there is wide variety of opportunities, and it will in fact be useful. And we have just seen the imaging demand has increased, and it will be a tool which would sort of help us. And also, I would encourage you to sort of if you have attended conference, you might have listened to few. Try to check in the YouTube as well. There are some very good lectures from experts in the field, and it's pretty clear. Like, AI is excellent in doing one thing very well, but human biology is quite complex, and the clinical diagnosis would require a physician's experience, um, and it's complex integration of many topics together. So what experts think is AI would free up radiologists' time. Uh, so it will eventually, we will be sort of interacting more with patients, showing them images, explaining them what it is, and also obviously more interventional procedures and other aspects to it. So moving on to the next topic, which is teleradiology. There are lots of essentially lots of places are outsourcing because they have a huge backlog, or they can't meet the demand. So obviously we many places can provide 24/7 service due to teleradiology. It would reduce the waiting list, access to specialist opinion for more remote hospital. These are all the advantages. Of course, there are negative aspects such as loss of training opportunity. And if the radiologists are sort of placed outside the UK, then if there is error or mistake, uh, how to sort of make them accountable? Are they involved in the revalidation sort of process? If not, how to close the loop? And most teleradiology might have a financial motive, so they're paid per scan, so it can be slightly tricky. But of course, they are highly audited, and there will be uh, lots of check as well. So in some places, they may not have access to patient records, previous imaging, and they may not be available for discussion with clinician, which will eventually lead to double reporting, which will increase the workload. And of course, it costs a lot of money. And here are some of the figures which shows every year how things are doubling in terms of expenditure. Moving on to the next important topic, uh, it's 24 or 7 days a week radiology. Of course, we all know that we already have emergency radiology service, but then the question is, there is more call to sort of do a bit more elective work over the weekend. Um, and of course, this is with the background that we can maximize the use of expensive radiology equipments, because these equipment cost a lot of money both to purchase as well as for servicing. So in order to do that, we would require a lot of funding and staff. The staff will involve receptionists, radiographers, HCAs, and radiologists. And lot of out of our service may impact staff well-being. Those are all the factors which are sort of need to be discussed if these things come up. Radiology workforce. Again, it would be good to know what's happening in the radiology world before entering. So 1 in 10 consultant posts is unfilled, and UK has third lowest number of radiologists per 100,000 population compared to European counterparts. And the number of consultants increased by 5% over 2012 to 2015. However, the number of scans increased by 29 to 26, 26 to 29%. So there is a huge increase in the growth of in the demand, but then the workforce has been a bit challenging. But people are trying to mitigate this by trying to increase the training post, sort of developing subspecialty regional reporting networks, and also to have a skill mix, which we discussed earlier. And of course, short-term solutions such as outsourcing, hiring radiologists from abroad are also considered. Moving on to MDT, which is a very important aspect in radiologists' life. It's central to treatment decision making. I would encourage you to attend few MDTs and see how people interact and how radiology sort of plays an important role in the MDT. Moving on to exams, obviously you might have read quite a bit, but there is first FRCR exam, physics and anatomy, and final part A exam, which is MCQ based, and then part B, which has long case, rapid reporting, and Viva. So it's important to know the structure. Obviously, these are hard exams, but as long as you study and as long as you work during your hours, then you should be able to get it. Sometimes people may take an attempt or so, but it doesn't matter. As long as you're putting your effort, you will eventually pass. And other important topic when you're choosing which place to go is radiology academy versus traditional training. Both have got their own advantage and disadvantage. So radiology academy is essentially Department of Health and RCR developed a few centers to train more radiologists. It's based in Plymouth, Norwich, Leeds, Wales, and Northeast. And it's a bit more supervised environment where people do a bit of their training in the academic setting and the remaining in the hospital. So there are advantages and disadvantages to it. So I would encourage you to go and check in the website and also speak to people who are training in both aspect to sort of find out how the training is. The other important thing in radiology is learning from discrepancies. So radiology, if there is a misdiagnosis or if there is any issues with the patient care, it will be discussed in the discrepancy meeting. Sometimes now they call radiology event and learning meeting, where it's supportive learning environment and trying to understand why the error has occurred. For example, errors could be due to many reasons. It can be people know that cognitive, or you by the end of the day you may be more tired, you may miss few things. Of course, it's not a justification, but it tend to happen when you're reporting under huge pressure. So it's to understand, is it because of the training, is it because a few things are rare? So it's just trying to be supportive and um, provide a learning environment to everyone. If possible, try to attend them if you get a chance. And also realm newsletters, it's available to only members, but if you get a chance just to have a look at it and see what it involves. And finally, I just wanted to touch upon things like current issues such as how COVID-19 has impacted on imaging volume during first wave. Few centers reduced their imaging by 30 to 60% because of cancellation of a lot of activity. And in the subsequent lockdown, most of the cancer imaging have continued, but just try to read around how it has impacted the imaging around the world, which has been like in terms of scheduling and complexity of scans. So that's the just basic overview of some of the important topics. Thanks for listening. All the best.
Thank you very much, Abhishek. That was brilliant and very comprehensive. So I'm sure everyone has noted the topics, and we'll go through it again when we provide the recording. So thank you again. Everyone, please feel free to post your questions if you have any questions in the chat box, and I'll pick them up and we can ask them to the panelists later on. Next up, we have Dr. Taimur Asgar. He's a brilliant radiologist. I can't speak highly enough of this guy. He's a ST6 senior radiology trainee in Sheffield. He's a interventional radiology fellow. He's close to his CCT, and he's also going for higher training in Canada as a post-CCT fellowship. So he will give us an overview of what IR entails, because I'm sure many people here are very keen to know about that. So, and that would be very useful insight from him. So Taimur, it's all yours. Feel free to share the screen.
All right, thanks, Asim. Okay, can you see my screen okay?
Yeah, it's the screen.
Grant. So my name is Tim. I'm one of the IR trainees in Sheffield, and I'm just going to give you a bit of an overview of IR training. So what is interventional radiology? So it's a subspecialty of clinical radiology with emphasis on non-invasive image-guided diagnosis and treatment. So it's a fairly broad definition, and it is actually quite a broad specialty. So it encapsulates all the different sort of subspecialties. So with vascular, you might be treating aneurysms, EVAR, TVAR, embolizing blades or fibroids. And then there's GI, where you might be doing biliary stents. Interventional oncology is also quite a bit significant segment and growing, with doing chemoembolization of tumors or palliative SVC stents for SVC obstruction, and nephrostomies and neurotech stents. And then pediatric and neuro-IR also might also get involved in those as well, depending on where you are. Something else that might be a bit different compared to the rest of diagnostic radiology is that you tend to be a bit more involved with other parts of the patient pathway. So many IRs do outpatient clinics, ward rounds, and have a separate on-call referral system. So Abhishek's already shown you this picture. So in terms of the training pathway, you would apply for clinical radiology, as I'm sure most of you have done. And then you're training to get a CCT in clinical radiology with an interventional radiology subspecialization. So it's a subspecialty of clinical radiology, but on your GMC certificate, it will say that you have a subspecialty in IR. And you do an extra year of training. So you'll do your 3 years of core radiology training, and that core training will also include some IR training. And then during ST3, you'll apply either locally or in other programs nationally for IR training number. So normally you do your interviews in ST3, and then your ST4 to ST6 will be mostly IR training, but you also do usually some general radiology skills, maybe half a day or 1 day a week of CT or general ultrasound. So that's the general pathway. Some deaneries have a more sort of holistic pathway where they do IR training from day one. So in Yorkshire, they're trialing a enhanced IR training pathway. In other schemes, they also do a focused individualized training. So in this case, you might say from day one, I want to do IR training, and then you'll do all your core training rotations, but you may also do 1 day a week of IR during ST1, 2, and 3. So they're doing that in Sheffield, actually. So people who say they want to do IR training, they have an option to do half a day a week of IR during first and third year. Neuro IR is generally a separate training program. So again, you would apply an ST3 for neuro IR training, and that is also 3 years from ST4, 5, and 6, which includes diagnostic neuro and neuro IR specific IR training. Pediatric IR training varies by region. So in Sheffield, we don't really do any pediatric IR training. In other places, you would do pediatric IR training as post-CCT fellow, or it might be included as your general IR training program. Something that I'll mention quickly, sorry, in the last slide is that this may change in the future. So direct IR training programs where interventional radiology has a separate application from diagnostic radiology may happen in the future, but currently that's not the case. So what was it like being an IR trainee? So this is maybe a typical timetable for me. So during a normal week, currently at the moment I'm doing Monday mornings, I'm doing upper GI endoscopy training. So that's not available in all training schemes, but it is in the Sheffield training scheme. And then Monday afternoon, I do a urgent IR list. So I'll be all the emergency procedures. So mostly include angioplasty for critical limbs. It might be thrombolysis or thrombectomy for DVTs. Sort of cases like that, emergency embolization for GI bleeds. And if there's none of that, then normally we have a few PICC lines that we need to do, which are sort of semi-urgent that we can do in the background. On Tuesdays, usually I do elective cases, so there'll usually be a couple of EVARs booked that will take up the morning, or sometimes they have a fenestrated EVAR, which will take up the whole morning. And then in the afternoon, there might be chemoembolization of liver tumors. On Wednesday mornings, I might do a clinic. So this is a vascular interventional clinic. So I'll mostly be seeing patients who need to be consented for IR procedures, so fibroid embolization or vascular procedures, or following up these patients after they've had the procedure. In Sheffield, we also see new patients as well. So GPs will directly refer patients with intermittent claudication or critical limb ischemia who haven't had any workup at all. They'll be directly seen by interventional radiologists, and we'll decide what to do with them. That can vary from place to place, but in Sheffield, vascular interventional radiologists are heavily clinically involved with patients. Once we've done clinic, I might have another elective list, so might do some more TACE, fibroid embolization, port caths, or Hickman lines. Thursday, might do some vascular reporting or general acute CT reporting. And in the afternoon, I might do some general radiology type service provision. So holding the duty radiology bleep or doing a general inpatient ultrasound list. Friday mornings, I might do vascular MDT. And then afternoon, it might be another urgent emergency list. So this depends on where you work. But in Sheffield, we rotate through the different interventional subspecialties. So this would be my vascular interventional timetable, but I might also rotate through GI intervention or Euro intervention, for example. So apart from the regular timetable, you also have to do on-calls. So in most training schemes, you have to do diagnostic on-call up until ST5. And then in ST6, you would do IR specific on-call. So I am an ST6, so I'm doing IR on-call at the moment. And in Sheffield, we normally do 1 day a week of IR on-call, in which you cover vascular IR and nephrostomy cover. And then 1 in every 7 weekends, I would do the whole weekend of on-call as well. One of the good things about the IR trainee timetable compared to other specialties is that you do actually spend most of your time doing in the angio suite doing procedures. So depending on the rotation, between 60 and 90% of my time is in the actual angio suite doing procedures. which is quite favorable compared to other specialties like surgery or medicine, where you'd be spending a lot of time doing sort of ward work and things like that, rather than learning your craft. So this is just an example. So last weekend I was on call, and the on-call starts from Friday 5 p.m. and finishes Monday 9 a.m. In Sheffield, you're expected to do a ward round of your vascular IR patients. However, I was lucky last weekend and there wasn't any vascular IR patients admitted, so I didn't have to do a ward round. And because of COVID, we're also discouraged from going to the ward. So sometimes we also go to the vascular surgery ward round to give the vascular surgeons a hand. But I didn't do that last weekend. I had to report all the vascular on-call imaging. So that was vascular CTAs, MRIs, scans for acute dissection, or emergency bleeds. And we also report all the sort of unstable traumas as well. In terms of the cases, I also did one ultrasound scan for femoral pseudoaneurysm. So occasionally you'll do a vascular ultrasound if there isn't a vascular stenographer in. In terms of calls, so switchboard will contact you as a first port of call for nephrostomies or any vascular queries. So this will be from the whole region. So I might get a call from Barnsley or Doncaster or district generals, or I might get a call from locally in Sheffield. Questions about what imaging to do for patients who are unstable and they're worried about bleeding, or questions about next steps in managing GI bleeding, whether they should undergo embolization or whether they need endoscopy first. And the last weekend that I did, it was actually quite reasonably busy in terms of procedures. So on Friday evening, I injected a femoral artery pseudoaneurysm with thrombin. And that was the same patient that I did a scan of the next day, actually, to see that the treatment was successful. On Saturday, I did a nephrostomy in a very unwell patient with a septic obstructed kidney. And they were on inotrope, so they were actually very unwell. And this was quite a satisfying procedure because they became quite well fairly quickly, actually, and they were stepped down from ITU the next day. I did an embolization of a right hepatic artery bleed. So this patient had a hepatocardiogenestomy revision, and post-surgery they presented with a bleed, and they were quite unstable. They had a couple of units of blood, and they weren't really ideal for taking back to theatre. So they asked us if we could embolize it, and we did. And then on Sunday, we also did a embolization of a inferior epigastric artery bleed. So this was a trauma patient, and they had bleeding into the rectus sheath, and we did a embolization of the inferior epigastric artery. So all these were quite satisfying procedures, and it was quite a busy weekend, actually. So sometimes I have no procedures at all. Sometimes you're coming in at 2 a.m., 3 a.m., which I did have to do with the GI bleed, actually. So that's an overview of the training pathway and what you tend to do, sort of your general day-to-day job during the week. In terms of pros and cons, I would say that IR is very satisfying. You get to do a lot of quick procedures which have a direct and significant impact on patients. So you'll do the scan, you'll report the scan, and then you'll do the procedure and often stop the bleeding immediately, and they'll often stabilize very quickly. Or the same with cancers, patients who have no hope, you can kill off their sort of liver HCC, or you can do a radiofrequency ablation or microwave ablation of a renal tumor and significantly prolong their life. You get to get involved in all parts of patient care. So especially, for example, in interventional oncology, you might be reporting the scan, presenting it at MDT. You might then go and do the biopsy of the liver tumor, and then you might consent the patient in clinic for chemoembolization or microwave ablation of the liver tumor, perform the procedure, see them on the ward after the procedure, discharge the patient, and then see them in clinic in 6 weeks and report their follow-up imaging, and then discuss again MDT. So you can get involved in all parts of the patient pathway. There's a huge variety. So if you like being a generalist, You can do intervention from head to toe, really. Do carotid stents, do pulmonary AVM embolization in the chest, biopsy, sort of everything, do fibroid embolizations, vascular procedures, GI procedures, pediatric intervention. So you get a huge variety, and it's a rapidly developing specialty. So this specialty will look different in 10 years. The technology will develop and people will be doing different procedures 10 years from now. And it's a highly sought after skill set, being able to do procedures. And that's true in teaching hospitals, and it's also true in DGHs. People want people who can do biopsies, drains at the lowest level, and do high-end intervention as well. And AI won't take your job, and teleradiologists won't take your job. So that's something I can give you a bit of reassurance. If you're doing something practical at the bedside, then you always will be in demand. There are a few cons. IR isn't for everyone, so it can be stressful. Sometimes you are doing embolizations in the middle of the night, and you have to be able to perform. And sometimes you get bad outcomes. Sometimes patients die, or your embolization is unsuccessful, or they have tumor recurrence after your ablation. And sometimes you have to cancel the patients or see them in clinic and tell them that. So that's gives you a bit of extra stress compared to diagnostic radiology, potentially. It can be physically demanding. So you could be in the IR and your suite all day wearing lead. Fenestrated EVARs can be quite demanding, especially because you're doing the procedure for sort of 3-4 hours, sometimes even longer. Some procedures have lasted a whole day. And wearing lead all day doing procedures can be exhausting and can hurt your back. So in comparison to diagnostic radiology, there's a lot of out-of-hours work, and that's not for everyone in terms of work-life balance. Yeah, you will be called in the middle of the night to do embolizations or emergent EVARs. You will be asked to review unstable trauma scans. So that potentially doesn't suit everyone. Some issue something that might be an issue in the future is sort of turf wars potentially with other specialties. So vascular surgery or other specialty GI or other specialties which do some of the work which overlaps with IR. Although I think there's such variety in IR and there's so much development and there's so much to do. I think this isn't going to be too much of an issue. You'll always have work to do, especially in interventional oncology, which is rapidly expanding. If there's some work that you can't do because it's taken by other specialties, there's always affinity work in other areas. I quite like doing diagnostic radiology, actually. So in my training scheme, I think maybe I'm not as good at reporting some types of imaging compared to my diagnostic colleagues. And in the future, there might be plans to make IR a completely separate specialty from diagnostic radiology, so that you are drifting further and further away from diagnostic radiology. So that's something I need to think about, is whether what is the balance of skills do you want? Do you want to be doing more radiology, diagnostic radiology, or do you want to be doing more procedure and clinic work? And then I think a minor issue is extra year of training, which I don't think is a huge issue in the grand scheme of things. I'm doing more than an extra year of training. I'm doing it almost like an ST7 year in Canada. So I don't think that's too much of an issue. In terms of your interviews, there might be some hot issues that they might ask you. So a lot of people are interested in IR at the outset. So if you tell them in the interview that, look, I'm interested in IR, then they might ask you specifically, okay, then what are the issues that you envisage in IR, or what are the challenges in training or service delivery? So the British Society of Interventional Radiology had a vote in 2019 regarding whether IR should be a separate specialty from diagnostic radiology. So at the moment, it's just a subspecialty, but they want it to be a completely separate specialty. So 80% of people were in favor of it being a separate specialty. So this is something that might happen in the future, but it might be 5 or 10 years down the line to make IR a separate specialty. So this is something that's happening in North America, especially in the US. So you have direct IR pathways where you're recruited separately to IR specific training. And the reason why we think some people think this might be a good idea is that you can then focus on more clinical issues, like have more time doing ward-based training or clinic-based training, which are skills that we will need as the sort of future IR training model. They might ask, you may talk about how to deliver 24 IR services. So there is a significant shortage of IR specialists, and embolization of postpartum bleeds or upper GI bleeds is not available in every center, or even nephrostomy service isn't available in every center. So there may be questions, and there's some solutions like having a centralized service or hub and spoke service, or covering larger regions potentially, or maybe even training people in other specialties, for example, to deliver some of the work. Skill mix is also relevant. So in my training scheme, some radiographers and sonographers can do acidic drains or taps, and acidic taps or pleural taps, for example. I talked about turf wars briefly. So this year there has been discussion about vascular surgical training and endovascular procedures. So a lot of vascular surgeons do want to learn some IR procedures. So in Sheffield, it's not been a problem. I've had plenty of exposure to vascular procedures, but in other places, things like EVAR or TVAR might be done in the theatre by vascular surgeons. So that might be an issue in the future. So that's something that you might discuss. Centralization is a common theme in most specialties. So things like ablation or fenestrated EVARs or TVARs are moving more and more towards teaching hospitals and less from DGHs. And that's the same with vascular surgery as well. A lot of vascular surgical high-end procedures are moving to more and more centralized hospitals. Stroke thrombectomy is also a hot issue. So a large parts of the country don't have access to a 24-hour stroke thrombectomy service. Most stroke thrombectomy is performed by neuro-IR specialists, but there are talks about having some of this service delivered by general IR consultants or even neurosurgeons or neurologists. So this is a hot issue at the moment. Diversity is also something that's been a more of an issue in the past year or two, especially recruitment of more women in IR to make it more family friendly or more work-life balance, because doing more out of hours work is something that doesn't appeal to everyone. So there is talk about different models on how to get more people involved in IR and make it more sort of work-life balance friendly. So that's all I have to say. So I think if you're interested in IR, I would definitely encourage it. I think it's not for everyone, but I think what I would say to everyone is that doing procedures is an important skill. So even if you don't do full-time IR, I would still try to do some procedures. Being able to do biopsies, drains, these are skills that I think every radiologist should try and learn to do. Okay, thanks. Thanks for listening, and I'm happy to answer questions at the end of the evening.
Brilliant. That's a very, very brilliant talk, Taimur. Thank you very much. And it was very much needed because we don't have as much insight into IR, especially for those people who are just entering or planning to enter into radiology. So that's immensely useful. Thank you. Will you hang around for the questions towards the end, or do you want to take the questions now?
I can. It's up to you. I don't mind. I can answer questions now or at the end.
Yeah, at the end would be great if you can hang around.
Yeah, that's fine. I'll wait till the end.
Right. Much appreciated. Thank you. Saad, are you around?
Yes, I am, Asim.
Do you want to go now?
Yeah, that's fine.
Oh, brilliant. So Saad is one of our new trainees, and he'll be very happy to present his own experiences and give you some tips. He is training currently in West Midlands. So thank you, Saad, for doing this. Off you go.
Yeah, so Yorkshire, but easy mistake. But yeah, hi guys.
Yorkshire, Leeds, isn't it? Sorry.
Yeah, Leeds. So hi guys, my name's Saad. I'm an ST1 in the Leeds Bradford training scheme at the moment. So I'm just going to go through a bit about the Leeds Academy and the training structure here for anyone who's interested in applying to Leeds. So firstly, it is an academy. It has a very structured style of training. We currently have a cohort of around 14 ST1s, which is larger than most ST1s in other deaneries. And the way that it's structured is we have general radiology training for a year, which involves getting competent in 3 main imaging modalities, which are your plain film, ultrasound, and your CT. So we have 2 monthly rotations, which involve 6-month training in Leeds, which is your tertiary trauma center, and then 6-month training in a district general hospital. So the hospitals that we rotate to outside of Leeds, they are Bradford, Harrogate, York, Pinderfields, Huddersfield, and Airedale. So the advantages of being in Leeds are that you get a lot of cross-sectional experience here because it's a tertiary trauma center, and in your peripheral hospitals, you get a lot of opportunity to get involved in your intervention radiology and non-vascular intervention as well. And you get a lot more downtime to study as well. And in terms of academy days, we have our academy days in Leeds on Tuesday and Fridays until our FRCR Part 1, followed by academy days only on Tuesday. So before FRCR Part 1, our lectures mainly are held on anatomy and physics. There are a lot of internal exams as well, along with passing your FRCR Part 1 in March. We have an ultrasound assessment, which takes place in July of ST1, and a plain film assessment as well, which we do in ST2. So trainees are expected to maintain their Kaizen portfolios throughout as well. So that's our structure for year 1. In year 2, we'll have 2-month placements in different hospitals where we'll do 2 3-month subspecialty blocks. And they are generally your core subspecialty areas, which are your chest, cardiovascular, GI, GU, MSK, neuro, or pediatric radiology. So what are the advantages of being in Leeds? So firstly, it's very, very dedicated training days that you get. We have an excellent radiology academy teaching over here. We have quite a big academy within the hospital where we have Mac labs, simulators for vascular intervention. We have ultrasound facilities. And generally, because our cohort's quite big as well, it's generally quite a sociable environment where everyone's there to kind of support each other. And we have a centralized radiology academy manager as well, who always looks after you as well whenever you're rotating and make sure that they answer any questions that you have. So that's just a little bit about Leeds and my training experience here. I'm just going to go quickly through how I went about preparing for my interviews last year. So for my MSRA, which was at the start, which was used to obviously shortlist for your interviews, I used mainly past medicine for my clinical section and past test for the ethics section, which I found to be quite useful and similar to the exam. And generally with MSRA, I normally started a few months before, and you just got to kind of just carry on doing a little bit consistently throughout. And I know everyone's going to have very difficult and busy foundation jobs, but you've just got to maintain that level of consistency and try and do as many practice questions as possible. For the interview itself, for my portfolio station, I ensured that I did prepare my portfolio in advance. It's worthwhile, having a nice portfolio where you kind of know it quite inside out. They will ask you questions on your individual specific teachings that you've done, your audits, and you should be able to defend every single element of your portfolio. For the commitment, there are, again, certain themes that are always asked, to do with your motivation and reason to do radiology. And, you need to make sure that you have great answers prepared. And you need to make sure that you're thoroughly researched about, your curriculums, the exams of radiology, and, generally from your taster weeks, you need to know what the life of a radiology registrar and a consultant is. And every single answer that you give, you should try and link it back to your taster week as well. And RCR has some great documents on, AI, skills mix, teleradiology, turf wars, and 24-hour working, which I would definitely recommend reading. And speak to as many radiology consultants and registrars for their views about these different challenges as well, because you will be asked regarding those in your interview. So that's a very quick run through with the academy style of teaching that you get, and also regarding my interview experience as well. If anyone's got any questions, happy to answer them at the end or now, whenever. But yeah, thank you very much.
Thank you, Saad, very much for the quick overview. So I understand you have to rush, and will you come back for the question and answers, or do you want to take them now?
Yeah, I can take them now, but yeah, I can come back for the question and answers as well. It depends. If anyone's got any questions now, I'm happy to take them.
There's one recurring question that has been is, how are radiology training academies different from academic training?
Different from academic training. So we actually have an ACF post here in Leeds as well. And with academic training trainees who are in ACF, they're normally internally recruited in ST3. And with ACF and your academic training that you have, you normally tend to have around 25% time off. And they will normally work you up for a PhD with projects and things, but you don't have to go for that. But you do get 25% time protected towards to do your research. With the academies which are present, so I know there's one in the different academies which are present. I know Northwest and Mersey, they normally tend to have a 4-month academy block in ST1. Yorkshire is different, so we will carry on having this 1-day academy block in ST1. So it's 2 days until FRCR, then 1 day on Tuesdays. In year 2, we will also have the 1-day academy, which will be on the Thursdays. And in year 3, we have our academy days on Wednesdays. And generally, the purpose of these academy days are that they are going to go through all aspects of, certain things that you wouldn't see during your acute CTs. They will actually teach you regarding cross-sectional imaging, MR imaging, acute pathologies to prepare you for your on-calls. And it's quite good to have that tailored, structured teaching given to you. And if you are the kind of person who likes that, then I think having academy-style teaching is a great option to go for. So yeah. Any other questions?
Yeah, that's helpful. I think that was the main question for you. It would be great if you can rejoin us for the Q&A round.
Yeah, that's fine. No worries.
Thank you again, Saad.
Thank you very much, Asin.
Yeah. So next up we have Dr. Paracha. Mariam, do you want to take over? Mariam, everyone already knows Mariam. She has been right there from the beginning, and she's been super helpful. She's currently a radiology trainee in West Midlands. So Mariam, it's up to you.
Yeah. Hi, everyone. Basically, I do think that pretty much of the theoretical part has been covered by everyone. I just wanted to let you guys know that I do think that the fear of interviews is a lot, and I don't think so you should be that much fearful. I found it to be very easy for me, I would say. And the interviewers over there, they actually make you feel very comfortable. The main thing is that you need to kind of reflect your own experience. That is what I would say is more helpful in answering the questions. For example, if it can be tailored in any way, if they're trying to ask you, why do you think you're a good candidate, or why do you want to opt for radiology, something like that, any kind of question, you should try to put your own previous experiences into tailoring your questions. That is what they're kind of looking for, that how you're going to reflect on your practice, how you are actually trying to tell them what you have learned in your taster week. One thing I would say, I do think I have said it before again and again, that how I prepared was that I actually didn't attend any interview course or anything, because I was doing A&E at that point and I didn't have any time. I personally went to the radiology department over there and contacted the registrars. Radiology registrars are always very helpful, very pleasant. And I mean, they actually kept asking me questions again and again, and I didn't read any material myself. I actually gathered whatever was told. I met many consultants. So I would recommend everyone should do that in the coming week. Whenever you will get the interview calls, spend 2 to 3 days. If you get study leave or anything, you need to go to the department. Everyone has been through the same process. Many of the consultants would be the part of the recruitment, and they know what kind of questions or what they're looking for. So the consultant in my hospital, he was actually telling me, okay, I asked this. So that would be really helpful. Next thing, what I would say is I have written a few bits just for the sake how I prepare for myself. As I told, make each answer quite personal. Then reflect on what you have learned, what you have seen. You have to kind of tell them again and again what you observed during your practice, what you observed during your taster week. These are kind of the bits you are throwing for them to make them understand that you are actually showing your commitment to specialty. And that is what they're looking for. They actually didn't ask much of the detailed question. They are not looking for any radiology knowledge. What they're looking for is your kind of commitment and your insight into radiology. You should be really good in answering about yourself, about your positives, about your negatives. Always the radiology registrar in my trust, when I was preparing, he told me, try to tell your negatives in a way that they should perceive it as a positive. So that is how you need to tailor it. I would say that, I mean, I didn't do it myself, to be honest, but questions like about your CV, about yourself, why do you want to select radiology, these you need to kind of write. You need to kind of organize your answers, and then you can mix and mold whatever they will ask. Okay, as it has been told previously, you need to know about the FRCR exams. You need to know about the training structure, how you are going to cope with the pressure of a radiology registrar. Like, for example, when I started, you should tell them that you have observed an ST1 during your taster week. So as an ST1, I don't know if you guys have actually seen an ST1 or not. As an ST1, when you land into the radiology world, when I was there, I was completely blank. I had a background of medicine, but all we would try to look when we are working in A&E is a fracture, that's it. Consolidation, that's it. We don't know anything more than that. Actually, that was the case for me at least. But when I went over there and they were like, okay, you should start cold reporting and you should try looking how to write a report. And I was completely blank. So, and then a consultant I would like to quote told me that a good report should actually answer the clinical question. So these are kind of the bits you actually pick from people, what they say, and you try to quote it during your interview to show that, okay, you have been observing people and you have been trying to absorb what is going around. So yeah, I was telling, being an ST1, you have to report A&E x-rays, and they would kind of expect you to do it from day one, but there are always the registrars around who would help you. Then I have got a fluoroscopy list to do, an HSG list to do, ultrasound, where I never actually find kidneys. Now I am, but initially you are just lost that, oh my God, why I have actually opted it, because you don't know how to hold the probe, you don't know how to communicate with the patient. So there's a lot of pressure when you're an ST1, because you are actually coming out of your comfort zone of an F2 or kind of medicine where things are going very smoothly, and you are entering a completely different world. Then we have got 2 teaching days. of anatomy and physics, then physics again. I actually didn't opt for, my parents actually told me to be a doctor and an engineer, and I didn't want to be an engineer because I didn't understand physics or maths, and now I'm stuck with physics again. So yeah, these kind of things they would expect you to talk about. And one thing I would say, we had a good smile. I do think I just did that. And I was very communicative, very chatty, and I was actually making them talk to me. That is what I felt. Because, and maybe yeah, one thing more, don't try to answer a question more than 2 minutes. Maybe that's what I was doing, and they had to stop me. Okay, let's go to the next question. So this is a thing. I had just got some bullet points about things you need to know, as I had told before, about your CV, about yourself, your positives and negatives, what anyone can bring to the world of radiology, or how to cope with the pressure of radiology, how someone feels that they are committed to radiology, what do they feel about exams, because everyone talks about how difficult FRCR exams are, how you can convince that, how you are convinced that you will be able to pass the exams. Then kind of you can try to quote any mistakes, any experience of radiology, who is your mentor, or any role model you're looking for in radiology. You need to know about PAC system. What does PAC stand for? These are kind of things which are quite usual for an F2 to come across, and it would be kind of expected of you to know if you are interested in radiology. Then, as it's been talked, the new innovations, like we are talking about artificial intelligence, then try to go through the UK legislation about radiation. It could be one of a thing that could be asked, or what I did study, like the shortage of radiologists. You could find various articles related to that. How much is the shortage of radiologists around the world or in UK? And yeah, teleradiology, outsourcing, I guess that's about it. These are a few bits you need to kind of note down and just read about it, and I do think you would be good to go. That's all from me.
Thank you very much, Mariam. That was very honest and a very personalized experience review. So yeah, I'm sure everyone found it very helpful, as so did I. So brilliant. Thank you very much for that. Okay, so moving on. Next up, we have Rima, Dr. Gauri Shankar. She is a Sheffield trainee from the best training scheme. I'm just kidding. But so Rima, are you there?
Yes, hi, thanks, Asa.
Brilliant. Hi, Rima. Yeah, all yours.
Thank you. Hi, everyone. So as Asa mentioned, I'm one of the ST1 trainees in Sheffield. And I feel very lucky to be there. As you know, I've started my training last year, so started in the middle of the pandemic. So it's been quite a new, unfamiliar kind of situation, I think, for many trainees starting last year. So a lot of my training has been virtual, as opposed to kind of from what you'd normally expect. So I'll just give you a brief background of what goes on day to day during my first year of training, and then I'll talk a little bit about how I prepped for the interview. So at Sheffield, we're a group of 8 ST1s that started together. We have a typical 5-day week, but out of those 5 days, there's 1 day of teaching of physics, which is usually a Thursday, and then we have some anatomy teaching a half day on a Tuesday afternoon as well. And that's kind of time for teaching. The remainder of the days, we tend to rotate round. So we have 3-month placements that will involve different kind of departments. So whether it's ultrasound or CT or just kind of working on plain films, which you'll do regularly anyway. So that's kind of just the general structure at Sheffield for ST1s. So in terms of how I prepped for the radiology interview, so I would say one of the first things I did, even before kind of preparing for the radiology interview, was to get a radiology mentor. I was lucky because I happened to have my supervisor as a radiology consultant at the time, so I was able to get in touch with him and just kind of go through my portfolio with him and try to identify any gaps in my portfolio, which was really useful. So for example, trying to get you know, an audit or a project ready for publication or for a presentation. I know that's a lot easier said than done, but definitely worthwhile trying to do that. The other thing is, you know, don't be afraid to get in touch with your radiology department. You know, everyone's friendly, despite what you might hear on the other end of the telephone. But everyone tends to be really friendly and will be really helpful. And we're usually so happy to have people come on board and join the radiology department. So you know, that was one of the things I also did. I just showed up and I just went to my radiology department. I spoke to the trainees there. I got involved. I sat in with some of the reporting sessions that they did, stayed for some of the on-calls that they did, just to find out, you know, what they did on their day-to-day, kind of on a day-to-day basis. I went in, you know, on my free time to assist with some of the interventional cases. Yeah, so I just basically tried to be friends with everyone and just tried to find out what they're doing on a day-to-day basis. So the second thing I'll say is do your research. As you know, radiology is really competitive and it doesn't get really any easier once you get through onto the other side either. So I'd recommend speaking to your colleagues about the lifestyle, how, like I said, how their week is broken down, how the on-call rota functions, how they go about studying for exams, what the structure of the exams are. I specifically looked at resources like Radiology Cafe, which I'm sure a lot of you are aware of, but also Radiology Nation, the Society of Radiologists in Training, MediBuddy, obviously the Royal College website, and the British BIR. So I signed up for memberships with BIR and Society of Radiologists in Training, and that just gave me access to events and webinars that I could attend and just learn about what the current issues in radiology are. So the other thing is I listen to podcasts. I don't know if anyone's into podcasts, but I found them extremely interesting. So Radcast is the one that's produced by Radiology Cafe. There's obviously the RCR podcasts, which are quite in depth, but just useful to help learn about current and relevant issues in radiology. And also just focus on kind of getting the basic information about radiology training. So the timeline of exams and at what stage in your training you'd be writing the exams, what the exams actually cover, what is involved in the radiology portfolio. So what kind of achievements that you might need to do in order to get to your appraisal and complete your ARCP to move on. Look at the curriculum. Obviously look at deadlines as well for applications. So just do your basic research. And finally, I think kind of also reinforcing what Miriam said about making it personal. So it's useful to look at all the documentation on documents on the Royal College website and look at the statistics. And highly encourage that you do that. But also look at your own experiences and really, really analyze them and try to link it back to why that makes you want to do radiology more. I think that's, you know, if you find that link and you're able to bring that forward, I think in the interview, that will really get you across, and that will really make an impact. And I think finally, try to stay succinct. I know it's really difficult to do that, but try to have structured answers. And you know, like Mary mentioned, it's a 2 minutes, usually 2 minute, aim to have 2 minutes, but I would say even in the first 30 seconds, you should have said the meat of what you really want to say in those first 30 seconds to make that impression. So I personally attended Radiology Recipes, which is a course that is that's run by Dr. Mankad in London. That was last year, obviously pre-pandemic, but I found that really useful because just because there was a lot of practice. So again, I'd highly recommend just get somebody who, you know, just a buddy or any one of us to just help you out with practicing, just going through mock questions and practicing. I think that's really, really useful, and ultimately will help you be really succinct and structured in your answers. So yeah, that's it from me. Good luck to everyone, and I hope you get to join us very soon.
Thank you very much, Rima. That was very useful. The point about podcast was new to me, and yeah, that is something people should look into. Can I just quickly ask you, you brushed on this briefly initially. How has COVID affected your training, and what about redeployment? Could you kindly quickly elaborate on that?
Absolutely. So I think because this is now the third lockdown, we've managed to kind of I think, you know, I've had the benefit of, unfortunately, the last year trainees having gone through potentially getting redeployed, but we were notified by our deanery that that they would try their best to keep us within the department and you know, still kind of prioritize our training. So we've not been asked to be redeployed, which is great for us. However, our training has been impacted to some degree. So obviously a lot of the patient contact type training, so for example, ultrasound training particularly, we've had slightly, you know, we've got an extremely great department, and they've really tried to make things work, but it's been difficult and a stretch on the department to try to get us to have ultrasound training, and I don't imagine that that would have been as much of a struggle. The other thing is obviously with getting things verified or checked by your colleagues, it's not so much that you can kind of walk in and go and see a colleague so much anymore as pre-pandemic. So obviously that creates a bit of a barrier. But to say, on the other hand, you know, we've had a lot of our teaching virtually, which can be an advantage, but also a disadvantage, depending. So, for example, the physics teaching we've had it all virtually, which means that all our practicals have been kind of scrapped, obviously. Which you know, physics is complex enough, as I'm sure everyone would appreciate. But I think the extra kind of layer of virtual teaching does make it a bit difficult to grasp things at times. So, but we're making do. I think we're doing the best that we can.
Thank you. That's very useful. Yeah. Will you hang around till the end so that we can direct some questions towards you? Yeah, that would be very useful. Thank you.
Thank you.
Next up, we have Dr. Safia Rahman. She is a trainee, especially in nuclear medicine. She's training at Oxford, and she has kindly offered up her time to give us the insight about Oxford training as well as about nuclear medicine. So Safia, up to you.
Thanks, Asim. I'm Safia. As Asim said, I'm ST7 in Oxford Dentry. So unfortunately, I've lost my presentation due to problems with my laptop. So I'll go through what the nuclear medicine training entails. It is a 6-year program, and you enter at SP3 level to the program. And if anyone has done some sort of core training, either core surgical training, core medical training, even like core pediatric training with their postgraduate exams like MRCS, MRCP, or MRCPCH, then they are eligible to apply at ST3 level. So the interview, at my time, the interview took place at the same time as radiology, but the panel was different. And it was on the same day. I don't know how it's being run these days, but it was the first time they had advertised the training slots in nuclear medicine. So we had quite a few, like I think it was 7 vacancies available. But I think now, as time has gone past, so there are only few training slots available each year, 2 or 3 maximum. But the good thing is a lot of people still don't know about the program. And so there is there is a scope. If you want to do radiology and radionuclide radiology, then this is a very good program because it's quite diverse. So once you start at ST3 level, for the first 3 years, you are just training like any other radiology registrar. What you do is basically spend 80% of time in radiology, which is just like any other radiology registrar. And there's different training schemes have got different ways of managing nuclear medicine training. So some people do full 100% on-call rota with the radiology registrars, and some do just like 80% of the on-call rota. So for the first 3 years, you just train like a normal radiology registrar. You take the FRCR exam. So FRCR exam is must for training progression. And then once you have done the FRCR exam, then what you do is you move on to the higher training, which is like the last 3 years of training. And in last 3 years, what you do is basically you switch over to 20% radiology and 80% nuclear medicine. So 1 day a week is you do general radiology with the other registrars, but the 80% is nuclear medicine. So in nuclear medicine, there is a bit more diversity. So if you like patient contact, you get a bit of patient contact because you do radiotherapies, so like radioiodine therapies, which is for benign and malignant diseases. You also do lutetium therapies, which are used in neuroendocrine tumor therapies. And then you also do CERT, as someone mentioned, so yttrium-90 injections and all those things. So you can see some patients. At the same time, you can report scans like PET-CT, SPECT scans, and the normal basic general nuclear medicine like MAG3 scans and bone scans. So there is a bit of variety in it. And then besides like therapies, you can do nuclear cardiology as well. So you run the cardiac stressing at some centers. You are the one who run the tests, and then later you report the myocardial perfusion scintigraphy as well. So there is a lot of variety, and there's more scope. Especially if you are you get bored from stuff, then it's very good. And with the best thing about PET imaging is that it's ever expanding. There are new tracers coming, and now with the stress on personalized imaging, there is more focus on getting new tracers, so you can better stage the diseases, and then you can target the lesions as well. So the new tracers which have recently become very which are now being increasingly used are PSMA imaging. PSMA, they can ask you in interview about new tracers as well if you are appearing for nuclear medicine interview. So new tracer PSMA imaging has it has become so frequent, it has become so popular because it really affects the staging of the prostate cancer patients. And now it's being increasingly used in staging. And if someone is interested, they can read about PSMA study, which was recently published, and it's very like everyone is like getting more and more focused on it. And now there is more focus on therapies like lutetium therapy for prostate cancer. They are doing trials on that to see if it affects the management of the prostate cancer patients. So there is a lot that available in nuclear medicine. But the other way you can do just the radionuclide radiology is like you can apply for training at ST1 level for the first 3 years. You just train in general radiology, you do your FRCR exam, and then you just like any other radiology registrar who takes a subspecialty interest, you can take radionuclide radiology as subspecialty interest, and then you can do 2 years of radionuclide radiology, so which will include reporting basic nuclear medicine scans and SPECT CTs and then the PET scans. So you can do it this way, or the other way is at ST3 level. So there are 2 ways to enter like either radionuclide radiology or the nuclear medicine physician. The other thing, which is a bit like, it's a bit exam intense specialty, I would say, because you enter at ST3 level and you need to have postgraduate qualification at the time when you enter the training. Then you have to do FRCR exam. And afterwards, in last 3 years, you have to do the nuclear medicine diploma. So it is an essential part of the curriculum that you have to do the diploma, which is done by the King's College London. And the diploma is quite, it is quite intense in terms of the fact that you have to do a lot of physics, you have to do a lot of like chemistry, you need to know a lot of like basic physiology to be able to like interpret the scans, because it combines the anatomical as well as the physiological imaging. So if someone is not like into too much studying, I would say, then probably it's a bit difficult, especially because you have to do 2 qualifications during 6 years time. But otherwise, the good thing is that you can choose not to be on call rota, because it's usually 2-week scans that you are reporting, so they don't need to. If you don't want, you can negotiate your contract and not work as on the on-call rota as a consultant. And the other thing is that there is not many people take the specialties, so there is a lot of like lots of consultant jobs are available at the moment. So, and there is as the field is expanding, so there is a lot of scope for private work in future. And now one thing which I wanted to discuss was that there is like it is like you can the only problem with this is that you have to work in a tertiary care setup, because most of the DGS won't have PET scanners available, and you have to take part in MDTs quite frequently as well, because a lot of MDTs depend on PET scan reports as well. But there is like scope for either some people even go for cardiac imaging, so they just move on to myocardial perfusion scanning and cardiac PET reporting. So there is like other things that we do is neuroimaging. So we do DAT scans and PET scans for dementia and epilepsy. So there is lots of variety available if someone wants to have that sort of variety in their work. Yeah, that's it. And as a training program, Oxford. So Oxford is like a very, very small deanery, which is very good in terms of that most of the rotations are really in nearby hospitals. So you don't have to commute a lot, that you are really well supported, because the rotations are few. So you get to spend most of your time in the main tertiary care center, which is the John Radcliffe Hospital. And you do on-call work over there. So there is a lot of like, it feels like a family at the end of 5 years. You become like really close. The registrar body is really closely knit together, and you know every person, because when we come from other specialties, you usually rotate through different specialties, and it becomes really difficult to get that sort of feeling where you develop like really nice relationships, working relationships with your colleagues. So that's very good plus point of Oxford Deanery. And otherwise, like the teaching and training is very good. So overall, it's a very good program. And another good thing about radiology in general is that trainings are really well supported most of the time. And you are not just like you go through a structure where you initially start with plain films, reporting and ultrasound, and then you slowly move on to the on-call rota and slowly take on the more senior roles. So it's not like you start on the day one and you are expected to do on-call. So you're quite well supported in the program. Thank you.
Thank you, Sophia. That was very useful and enlightening, especially about nuclear medicine and Oxford training. Thank you. So there are quite a few questions for you in the chat box. I see you have been answering questions already. So you can address them in the chat box, or we can do that in the Q&A round at the end.
Yeah, sure. Thank you.
Thank you. Next up, we have Dr. Bar Whalen. Bar, are you around?
Hi, yes.
So Bar is a brilliant radiology trainee. She scored really, really well last time, and she has got into Imperial. So it will be great to have your perspective about radiology preparation for the recruitment, as well as about the London training schemes, please.
Hi, so I'm currently an ST1 in Imperial College. And I think that one of the biggest kind of strong suits for being in a London training spot is, first of all, the fact that geographically you're quite limited. It is really helpful that you don't have to kind of relocate every time you're moving to a different hospital, but also the kind of type of hospitals that you have. So clearly we do have most of the subspecialties within Imperial. So we can stay for our subspec training as well, which is quite guaranteed, which is nice. But otherwise, if you want to do something that is not available, or you just want to change the trust, then that's available for you as well. As part of London, and I think it includes the KSS Deanery as well now. You will apply during ST3, and there will be interviews for the different subspecs. But even if you do stay in your own, even if you stay in Imperial for your subspec training, you still have time that you can go to, it's basically the biggest centers that you can. So all of our pediatric subspecs go to Gosh for at least 6 months, if not more. Chest can go to the Brompton. So it's the leading centers in the country that you can kind of get an eye and just get all of the information and knowledge from the consultants working there. Otherwise, again, you're working in a great center that is just incredible research-wise as well. So we're very encouraged to pursue research and publications. And obviously we have that support from the consultants as well. But apart from that, it's basically the same kind of more apprenticeship-like training scheme, which of course was affected because of COVID. A lot of our consultants are now reporting from home. So we don't get that one-on-one time with them that the previous trainees did have. We do substitute it by doing the sessions either on Teams or over the phone. But again, it did lose a lot of the personal aspect and social aspect that they used to have, and hopefully will come back soon. I don't want to bore you with because I think a lot has been said, and I don't want to reiterate things that were already kind of discussed. You've all done the MSRA, so hopefully everybody got the scores that they needed to get the interview. But as for interview prep and how I approached it, I think you have to be very systematic. Like you were very systematic at getting your portfolio done and you ticked off all the boxes. This is not the time to kind of lay on your laurels and not give the extra push. What I did is, if you if you went to an interview course, I know all interview courses will send you questions that are practice interview questions. If you haven't done a course, Radiology Cafe has a list as well. Do sit down, don't write big long answers, but put bullet points of what you would say and then practice it. I basically made my partner sit with me for about an hour a day for a week so I could practice it. And by the end, everything was down and I was able to give really succinct and quick answers during the interview. And I think that made kind of all the difference, really. Especially you have time in advance to put examples. So everything you say, especially if it's about yourself, try to think of an example from your life, either from work, from previous experience, that will support what you're saying, because that's what they're looking for. They don't want you to say that you're very punctual. They want you to show that you were able during 1 year to be so organized and so kind of on it that you've managed to publish something and do an exam and do your work and still have a family life. So always have these supporting examples to back what you're saying. Practice. That would make all the difference. And specifically, I'm going to touch about the kind of radiology workforce questions that may come up. These are kind of points of contention among radiology consultants and people who have been in the system. And obviously each consultant will have his own point of view and what he thinks should be the way for the radiology department to move ahead. Your role is not to give the answer in these questions. No one expects you to decide if a department should have a 24-hour service or not. Your point, what you need to kind of point across is that you're aware that these issues are there. You're aware that this is the pros and cons of having one option, and these are the pros and cons of having another. And the fact that that's what you need to show. You need to show that you're involved enough to know the meaning and the consequences, but don't give an answer because you never know who's sitting in front of you and what their actual reasoning for an answer is. Other than that, really just try to keep good eye contact, smile, and just try to be you're not going to be relaxed, but try to at least show that you are and you're engaging. And as previously said, be succinct, because if you can kind of pull all of the answers quickly out of your hat, you will. I had time that they basically asked me, okay, is there anything else that you want to tell us? And this is the time when I knew exactly what I wanted to say, because I sat in front of the person specifications, literally just print a copy out and make sure that you can give examples, stories. It was easier for us because we had a paper portfolio, so I could show reflections that I've done about specific things that are written in the person's specification, and that's what they want to see. So that will, I think, will kind of guarantee you to have a really good score in your interview. Is that okay?
That's brilliant. Thank you. Thank you very much, Ba. I certainly reiterate and agree with most of what you have said, especially with regards to interview prep, practice, and having bullet points and knowing what you're going to say beforehand is really important, rather than thinking about an answer while sitting in the interview. So practice, certainly. Yeah. Thank you again, Bar, for answering most of the questions in the chat box. I'm sure we will have some more questions for you in the end. So it would be great if you can hang around.
Sure thing. And good luck for everybody.
Thank you. Vivek, are you around?
Hi. Yeah.
Yeah, brilliant. Thank you, Vivek, for joining us. Vivek is a radiology trainee in West Midlands, and he has kindly offered to give us an overview of his training scheme and his personal experience of how the recruitment was. Up to you, Vivek.
Oh, hi, everyone. So my name is Vivek. I'm working as ST1 in University Hospital of North Midlands under West Midland Deanery. And so, yeah, about the training scheme or hospital where I am right now, it's we've got 7 radiology ST1s that are working under this trust. And the good thing about the Stoke rotation is that most of the job will be basically located in the same hospital. So there's not much of moving around or rotation that'll be happening with this job. So, and by the way, an interesting thing, out of 7 of us, 5 ST1 trainees are international medical graduates, which I think might be an interesting and motivating factor for all the international medical graduates who are planning to apply as an ST1. And yeah, I think regarding the preparation aspect, a lot has already been covered. I think one aspect that I felt was common to both the MSRA and the interview aspect that I found was extremely useful to me was the time management aspect. It'll be really useful to just make sure that although you might have a lot to say, but just it would be a good idea to try to limit yourself to a specific duration and not over exceed it, else you're likely to miss out on certain points. And I believe apart from it, rest everything else has already very well been covered by like other ST1 trainees. So I suppose, yeah, is there anything else should be covering? I'm sorry, because everything else I believe has been very well covered by all.
Yes, thank you. That's very understandable. Yes. Yeah, so we are done with the speakers of the day. So thank you everyone for taking your time and for giving your own perspective. And I'm sure everyone will find it super useful. We just have the Q&A session now. We can have that for the next 10-15 minutes and then we can wrap up the session. Before we go to the Q&A, I just wanted to quickly say, if most of you already know me, if someone here doesn't know me, I'm Asim. I'm a consultant neuroradiologist. I'm currently working in Salford, Manchester. I did my radiology training in Sheffield with Taimur and Rima. It's a very good training scheme. With regards to interview prep, you have had very detailed overview as to how to prepare, what themes to prepare, and how to approach the interview itself. What I would suggest everyone is sit down after this session, make a note of the topics that you need to look into. You need to have an idea about each of the topics so that if someone asks you a question, you should be able to say something. You don't need to give a detailed explanation because first of all, you don't have the time, but you should have some insight into the topic. So just basic knowledge is fine. That is all they expect of you. Also, they want to know if you have shown interest towards radiology. So that would be through your portfolio, it would be through your case study, it would be through your publications and etc. and things like that. And it will also come across whether you have spoken to radiology trainees and radiology consultants or not, because when you speak, that insight that will easily show, especially because the consultants are sitting across the table. They would know whether you actually have spoken to anyone or not, or whether you're just talking from books. So this is very useful. You've got first-hand insight now from the radiology trainees. So use that, write it down, make points, and practice, practice, practice. There is no other way. You have very limited time. 15 minutes is not a lot of time, especially when you're really stressed. So practice in front of a mirror or record yourself and review it, or sit down with your partner, practice. You should have a written up answer, at least an idea, some points that you should be able to speak. So practice, practice, practice. Great. So I won't take too much of your time. So let's move on to the question and answers round. May I request all the panelists to be around. For the candidates, for the members who have joined this session, could you, if you have a question, please raise your hand, then I'll pick them up and direct it towards the panelist, if that's okay. I see that there have been a lot of questions that have been asked. already in the chat box. Shubhra, yeah, you can unmute yourself and you can direct your questions to any of the panelists. That's fine.
Hi, SM. Thank you very much for the overview, everything. Thank you, everyone. Thank you for the all the inside out of things. I just wanted to ask, if they ask us why radiology, can we give some bullet points which are really, you know, that can actually, I mean, that is something they are literally looking at. I mean, we can always say that, you know, we enjoy looking at scans. It's kind of a specialty where it's kind of solving puzzles. We did MDTs, we are solving, you know, problems and everything, but some bullet points where we can actually, you know, make them sure that yes, we are for the specialty.
Bart, do you want to take this question, please?
Hello. Hey. It's really difficult that they want to know, but I think that, as I said, the person specifications is basically what they're looking for. They've given it to you kind of on a platter. You just need to show that is you, where you fit in, and how, just give examples of how you demonstrate that you're the person that they want. There's no easy answer. It's not a very kind of, there's no certain question, but I think that that's the best way that you can prepare yourself for the interview.
Right.
Thank you.
Thank
Bart.
you. Right.
You're welcome.
Anyone else? Please raise your hand and we can direct your questions. In the meantime, can I, there were a few questions that were asked in the chat box as well. Abhishek, are you around?
Yeah.
Yeah, so there was a recurring question about academic training. How does the recruitment work? How does the training work?
Okay, so the academic training in most places, that's in London, Oxford, Cambridge, these are the centers which take more academic trainees. Obviously, there are some places, some posts, depending on how much funding is available. So the interview takes place 1 month before, so generally in December. So the application deadline will be in November. Obviously, you need some research experience. I had a PhD in PET imaging. So I think they're looking for a strong research publication record, although it really depends on the year. Like if you can demonstrate you have those qualities and you're interested in research, and if it's the right fit, you might get it. But because the radiology ACF posts are quite low, 6 to 10 posts a year, it can be competitive. Challenging thing is you have 25% time for research. That is 25% of the time is taken away from your clinical work. So you are given less time to get equal competence, which is challenging. So historically, people know quite a few academic trainees underperform in terms of their reporting target, and their exam pass rates can be low because of the less exposure. So these are the real challenges. But if you're interested and if you have the background, definitely give a try. In Cambridge, the interview, I had an interview with a panel of 8 people for half an hour, which is mainly asking about the research and what I want to do, what are the local strengths. So you need to prepare slightly differently to that. And obviously you need to get benchmarked in the clinical as well. So that's an overview. I know it's a bit challenging. I mean, here in Cambridge, most of the times they take post-PhD, but sometimes they have taken pre-PhD, although the program is designed so that people can get research experience to get into PhD. Yeah, it's overall good. We have very good research set up here. So yeah, give a try if you're interested. Thanks.
Thank you, Abhishek. While you're on that, can I quickly ask how competitive was the post at Cambridge?
Yeah, I think they would have 30 to 40 applicants for a post. I mean, it's obviously they won't disclose the number exactly, but based on my application number assessments and things like that, indirect assessments, they generally have 30 to 40 posts. But yeah, the interview was quite intense in terms of panel of 8 people probing you on different aspects of research. Also about Cambridge training program, briefly. Cambridge, Edinburgh's is major trauma center, transplant center, neuro center. So we have good sort of exposure to all aspects of imaging. There are 60 consultants, 40 registrars. So it's a huge department with all subspecialty work. So it's generally it's good. We have regular morning teaching between 8:15 to 9, and then we have 2A teaching on every Wednesday afternoon. There is a physics teaching for the first years on Tuesday afternoon. There will be lunchtime teachings. Wednesday 5 to 6 forum, which is speakers, expert speakers will come and speak on, or our consultants will talk about important topic. So it's quite really good, and the supervision is quite good as well. I would highly recommend you to rank Cambridge quite high.
That's very useful. Thank you very much, Abhishek. And it clearly shows that you have put in a lot of work and clearly were the best among the best. Well done to you.
Thank you.
Great. Okay. Next general question, is Rima around?
Yeah, I'm here.
Hi, Rima. So there was these general questions about what about the on-calls? Are the on-calls from ST1? And do you have any senior person along with you to support you, or do you sign off your own stuff?
Yep. So I think it varies depending on the deanery, but in Sheffield, we do start on calls from ST1. So it typically works out to 1 in 7 weeks. We are definitely paired with someone more senior. So at least one other senior registrar from ST3 or above. Sometimes we may have more than one. We also do have an ST2 trainee who joins us. So you're not unsupported. Basically, you've definitely got multiple colleagues around. You can report, so and you get to see a lot of the trauma cases as well that's coming in on an on-call basis. So it's really interesting and really good experience.
Thank you, Rima. That's useful. Thank you.
Timur,
I'm just going to shout out one thing about that.
Go on.
So when you're, and now it's going kind of a bit ahead, when you're ranking your preferences for jobs, one thing that you should kind of look into is the type of scheme that you're going to apply to and your personality type. I know that I'm a person that kind of likes to dive into the deep end because that's how I learn better and quicker. And Imperial is just like that. So you're technically from June doing on-calls. We have 2 people on call. One needs to cover a renal transplant site and the thrombectomy center, and the other covers the Central London Trauma Center. So it's quite hectic, and it's quite kind of, you need to kind of dive in quickly. Some programs I know, especially in London and kind of in Kent, I think don't even have any night shifts or on-calls that are kind of out of hours. So when you're looking into the programs, do check to see what is more suitable for you as well. Sorry.
No, that's very useful. Thank you very much, Bar. Timur, are you around?
Yep.
Thank you. Yeah, there are lots of questions about IR, and I saw that some of the questions you have already answered. But the general theme was, how competitive is it to get into IR training?
So obviously the main thing is getting into radiology training in the first place, and then you won't have to. You apply at ST3 level, so you have to have done your part 1, and usually they want you to done part 2A as well. Generally speaking, most people who want to do IR can do it, but it can vary from year to year. So in my year, 4 or 5 people wanted to do IR, and there was only 2 posts, whereas the year below, only 1 person wanted to do it, and the year above me, there was only 1 person who wanted to do it. So most people who want to do IR can usually get a post, but sometimes you might have to apply outside your deanery. For sure, there'll be somewhere in the country that doesn't have trainees that are interested that year. So yeah, it's a little bit competitive, but I think most people, if you want to do it, then normally you're able to get a post.
Thank you. There was another question. Can I quickly ask everyone to kindly mute themselves, please?
नहीं बस लेटी है बस ठंड लगी थी थोड़ी
Kindly mute yourself, please. All right. Sorry, Taimur. There was another question about is there an increased risk of radiation exposure with IR, and should that be a concern for someone with comorbidities?
I don't think it matters if you have comorbidities, but there's a slightly increased radiation exposure compared to diagnostic radiology. But you always wear a badge every day, and you're monitored every month or every few months. They check your dose, and there are strict annual limits and quarterly limits. And if you go over that, then they will look at it very carefully, and sometimes even give people time off or tell people not to go to the cath lab if you're doing a lot of exposure. But the equipment's getting better, the doses is getting lower for, and a lot of the procedures don't require any radiation even. So I think it's not a big issue. Most people who do aren't really that bothered about it. There are trainees who do IR training during pregnancy as well. They just wear a lead jacket. So with the right protection, I think it's not really a major issue.
Thank you. There's one more last question for you, if you don't mind. Are the procedures mostly consultant-led in IR?
So by the time you reach ST6, you'll be doing most procedures as a first operator. By the time you reach ST3, ST4, you should be able to do most biopsies, drains, aspirations independently by yourself. So over the 3 years, you will become more and more independent. Normally the supervision is very good. The consultant's there watching you or is scrubbed in with you, or they're always there available for help. All my on-call cases, I normally have a consultant with me, and normally they let me do the procedure. There are a few procedures which are a bit more, require a bit more experience, a bit longer to learn. So fenestrated EVARs or carotid stenting or stroke thrombectomy, for example, that's probably something you'll continue to learn after training, and you might have to do further training as a consultant. But usually support is very good, and by the time you reach ST6, you're usually able to do most procedures, sometimes without a consultant in the room.
Thank you, Taimur. That's very useful. Thank you. Thank you again for your time and for your insight. If there is any other questions for Taimur, please feel free to ask with regards to IR. Do we have Saad still around? No. Then Vivek, can you take this question, please?
Hi. Yeah.
So it was about how can we demonstrate commitment to radiology? It was quite a generic question, but it's about commitment to radiology.
Okay, so I think the starting bit might be doing a taste a week. That'll provide you a lot of insight about how exactly the department work, how like you'll probably during that time, it'll be a good idea to find some opportunities to go for one of the radiology audits or something, which is and while trying to try to go for an audit, which might be a simple one and which you can complete realistically the audit loop and present it somewhere, because that is something that will be fetching you full points about the audit aspect and show commitment to specialty simultaneously. Similarly, like Rima had mentioned, there are a number of societies which one can take membership of and attend their events, like British Institute of Radiology, BIR, the Society of Radiology, Radiologists in Training is another one such forum. And there are many such, specialities which are there. And once you get enrolled in them, there are lots of events that keep happening, and you can register for some of them. Some of them are free events as well. And once you register for those events, you can get certificates as well, which will further demonstrate your commitment. Simultaneously, while doing these, it'll be a good idea to write a reflection as well about the events that you're attending. Yeah, I think these are the major things that one can do. Apart from it, in the long run, there are things like research related to radiology or publication that one can be involved in. But then that is something that takes longer time. But then in the short run, these are the things that one can do and demonstrate this, commitment to the specialty.
Thank you, Vivek. That's useful. Thank you. Mariam, are you around? So there were these general questions, Mariam, about this time being a different format. Because of the pandemic, we just have one station for the interview, which I believe is about commitment to radiology. The questions are around portfolio. So the questions are like, can we still talk about courses or presentations which you have done after we have submitted portfolio? And can we talk about the achievements that have been done?
Sorry, what did you ask last?
So about achievements and about courses or presentations which we have submitted, and those which we have done after the submission.
Okay. Yeah. I would always say that there is no harm in telling your achievements after the submission. I do know that they specifically mentioned the dates. I don't know how much they're actually going to follow it. The other thing is, when it happened for us, the thing was that the portfolio station was entirely different, and the commitment to specialty station was entirely different. So there were two stations. So I particularly didn't talk much about my portfolio. The only thing is, as I have told previously, I kept mentioning, for example, again, if they ask about commitment to specialty, I particularly tried to mention that I had, presentations at national level, stuff like that. So you can always tailor your answers however you want. There is no set format they are looking for. And I would say again and again, try to mention whatever you have done. Don't bother about when did you do it. Was it in your med school? Was it like 1 week before your interview? That's fine. That's entirely subjective for them if they want to accept it, if they don't want to accept it. I don't think so that they would actually go for a negative marking for any of your answers.
Thank you, Maria.
You're welcome.
I've got a couple of questions for Safia and Bar, and then we should be wrapping this session up. Safia, there were quite a few questions, and I've seen that you have answered them in the chat box as well. But the general theme was, how do we enter nuclear medicine training? Is it through ST1 radiology recruitment, or can we enter it through the IMT or the CMT route?
So as I have mentioned, that nuclear medicine training is 6 years program, which is different from radiology in a way that in first 3 years you'll do 40% of radiology and 20% of nuclear medicine. But in the last 3 years, you do 40% of nuclear medicine and 20% of radiology. So the things which are different are that you'll be doing radioisotope therapies. That means radioiodine clinics, some radioisotope like cancer therapies and then you will be doing like myocardial perfusion scans and some neuroimaging PET scans and all those things. But if you want to go via normal radiology pathway, then you can always opt for radionuclide radiology as your subspecialty interest. So you'll still do the radiology training for 3 years. Then in the 4th year, you'll start doing more of radionuclide work with the basically participating in the on-call rota as well, and doing the general stuff as well. So you can do it both ways, but in that case, you'll be doing 5 years program, and then you'll be likely, you won't be doing therapies in the clinics and the myocardial perfusion scan as well, because it's more a different, it's usually done by the nuclear medicine physicians or the cardiologists. So that's different. So you can still do it, and it's quite exciting. Even like being a radionuclide radiologist, you can choose not to work on calls. Most of the work is 2-week wait pathway. So like it's the cancer work mostly for PET. FDG PET is mostly used for oncology work. So you will be, you can it's a bit good to now you can do opt to work as 9 till 5 job, and the way the field is going and expanding, the good thing is that you will never be out of job. There will always be option to work like part-time as well, if you can negotiate your contract, work for private setup in future. New and new tracers coming, so the field will always expand. So previously it was just FDG, now PSMA has come, which is being routinely used. Poly impact scans and neuroimaging for dementia, epilepsy, lots of work. The other thing is, although there is lots of buzz about AI, so I don't think so AI is going to take over nuclear medicine at all, because there is the PET reporting. The AI can tell you that this is like avid nodule or something, but it cannot differentiate between inflammation or infection. You have to look at the clinical picture of the patient. So, and it's very complex interpretation, looking at previous therapies that the patient has had. So there, AI will it's unlikely that it can take over PET imaging especially. And then like with new tracer coming up, I think the technology will fail to keep pace with the way with the new tracer, because of course each new tracer will have its own interpretation criteria, and by the time they develop softwares to overcome it, new tracers will come. So I think there's a lot of scope for it. Some people were asking about training schemes. So each training scheme has got its own way, and you cannot find this information online. You have to basically speak to the trainees. So about Oxford, the thing is that our training starts at ST1. So ST1 registrars spend 3 months each doing different blocks. So first, one is general block, introduction, where they just get introduction to the department for 3 months, then 3 months in ultrasound, 3 months in fluoroscopy, and 3 months of CT. That's 1 year done. During that time, they take the on-call exam. They've got a dedicated study day. So you're quite well protected in the sense that you don't directly start the on-call rota. In second year, you are put onto the on-call rota, which is you're a junior on-call. You're still not verifying your scans. You just do the on-call rota, and you don't do the nights, and you do the just the days, up till 9 o'clock, and weekends as well. So mainly you cover the ultrasound, you answer the phone calls and report some scans, CT scans if you get chance, and then they are checked by the senior on-call. So on evening shift, it's usually a senior on-call, which is ST3 onwards, who covers the basically who's the one who's responsible for verifying the scans. And the other good thing is that if the workload reaches a certain threshold, you are allowed to basically send the scans to for outsourcing. So we are very well protected in a sense that they keep, they don't push the trainees to make towards making decisions which they are not comfortable with, and the other thing is that all the scans are checked by the consultants. So even if you are ST5 or ST6, your scans get checked by the consultant, all of them. So that's good. You are very well protected during your training.
Thank you very much, Safia. That's very useful. Bar, are you around still?
Yes. Hi.
Sorry, I keep asking you, but there are lots of questions directed towards you. I see most of them you have already answered, especially with regards to audits and stuff like that. I think that's usually a burning question people have, as to what constitutes a good audit. I've done so many audits. Which one should I talk about? That was the first question. And the second question was, what about the previous experiences? For example, if I've done IMT, if I've done surgery, how does it make it more useful or beneficial?
So I think that for audits, obviously anything that shows that you made a change and made an improvement will be what they want to see. If you've done an audit and nothing, and you didn't change anything, then what's the point of it, really? I don't think that it has, nothing in the guidance last year said that it had to be a radiology related audit. But obviously it's better because you're applying for radiology for it to be radiology related. What I've done is basically, I just identified who the audit lead in the radiology department in the trust that I've worked in. And I sat down, I just arranged a meeting with him and saw, first of all, which running projects they already have, because that's an easy one that you can just join. And even if it's your first audit, you can kind of not lead it, but at least see what's going on. And of course, create good relationships with the department, which is also kind of very helpful. I think that what really helped me is the fact that I had kind of a consultant mentor in the department that involved me in things and was extremely supportive. If your trust is not as supportive, or you don't find anyone that kind of wants to guide you in that process, take the initiative. The RCR website has a fast kind of compilation of audits that you can use. They're very straightforward, and you can take just very easy ones. But as long as you kind of push for something that brings about change, so you need to kind of identify the gaps in your trust. That's the best way to get around it. If you just want to tick box, there's very easy audits as well. But I think that I push for, there's no reason to present something that you're not proud of. And if you're proud of it, it means that you made a difference. So I think that that's kind of how I would approach the audit. And the second question, again, I think that it's a lot of just the rhetoric rather than actually, I'm sure that whoever spent time in IMT or in surgery or in peds or anything has experience that will support their training. I have to say that one of my ST1 fellow colleagues has been a general surgeon for about 10 years before transferring for radiology. And to be honest, the guy looks at a CT abdomen pelvis and knows exactly what's going on. As for me, I can scroll up and down for 20 minutes before I even get kind of an inkling of what's going on. Put that forward. You do have a lot of experience and knowledge from whatever you've done before. Use it to your advantage to show them why you will be a better radiologist because of that experience, rather than looking at it as time wasted. That's, again, how I would approach it.
That's brilliant. Thank you very much, Pao. I think we have overshot by at least half an hour, but as you can see, there are lots of burning questions from members. So we will try and wrap this session up. Thank you everyone so much for attending, especially the panelists taking out time and doing this entirely voluntarily. That's absolutely brilliant, and I appreciate it very much, and I'm sure everyone here appreciates your efforts, so thank you. For the members, we will be putting a feedback form link soon, either tonight or tomorrow, in the WhatsApp group and in the Facebook group. Please, please, please fill this in. It is very useful, especially for all the panelists, that we can use it as a evidence in our portfolio. So that's one way of showing the gratitude for all this hard work. So thank you very much. If you have any more questions, then feel free to post in the WhatsApp groups. Most of our panelists are admins there. and they should be able to pick up the questions and answer them whenever they are free. And I also see that some of the panelists have given you the contact details. Please use it judiciously, ask what is relevant. Don't pass on the contact details to anyone else. It is important to maintain privacy and confidentiality. Yeah. So again, thank you very much for coming in. Does anyone else have anything to say before we wrap up? Any of the panelists or the members? Feel free to unmute yourself.
Can I just add something?
Sure, go on, please.
Yeah, so when I was applying, where there was restrictions on international graduates, so I had to wait 5 years to enter the program. So my advice for all of you would be, don't give up. That's the most important thing. Keep on trying, you will get there. If I can get it after waiting for 5 years, you all will get it. Just don't give up.
Absolutely.
Hello.
Absolutely. Thank you. Sorry, did someone else want to say something?
Yeah, thank you so much, Dr. Asim. It was a very great session, and I really benefited a lot from it. I have just got a job for junior clinical fellow in emergency department, and now I'm hoping to prepare for radiology. So one thing I've been told is to go for the radiology test a week. In the meantime, before I join for the post. I just wanted to ask that what else we can do. Are these the courses available on the radiology website to show the commitment to specialty? Because previously I've been working as a general surgeon, so it would be very for 6 months only, not for a long period. So how to go about that?
And this has been answered in the chat box as well. But Mariam and Rima, do you want to take this question, please?
Yeah, I mean, I prepared my whole portfolio when I was actually doing A&E. So test a week, obviously, you.
नहीं वही चल रहा है अभी तक वो छुरी मुझे लगता है it हुआ
Nehan, can you please mute yourself?
Yeah, please go on, Mariam. Thank you.
Yeah. So I was telling that I did my whole of the portfolio when I was in A&E. Try to talk to any consultants, pick any very easy audit topic. That is what I did. It could be related to something that is going on in A&E, and then you can tailor it to radiology. Start off with doing some actually a taste a week, and then take it from there. There are all online courses, online webinars are going on due to COVID these days. Try looking for any conferences. I have mentioned previously that UKIU actually accepted 3 or 4 of my audits. And again, as Safia said, that if I can get it, I seriously tell people that anyone can get it. There's a lot of kind of misnomer that is going on when people say, oh, radiology is something that immigrants can never get. I got that within 2 years when I landed in UK, and then they always say, oh, FRCR exams, people don't tend to pass it. I do not think that is actual case. People when I was working in A&E, people actually told me, oh, why are you even applying? You won't even get it. When I got it, I told them I have, and they were like, really? And I was like, oh, did you think that I am not that good that I will get it? So just keep trying.
Brilliant. Thank you,
Thank you
Mariam.
so much. Thank you
Rima,
so much. One last thing.
Yeah, go on, please go.
Just wanted to know about the WhatsApp links you have talked about.
Yeah, sure. If you're not already in it, please drop me a message with your WhatsApp number. We have a dedicated WhatsApp group for those who have applied this year, and some of them are also those who are going to apply the next year, but it's mainly for those who have applied this year. And we have quite a few trainees who have been successful, so they should be able to guide you through that. So please drop me a message and that should be fine. Okay, brilliant. So any final words from Rima or Daimur, Saad, Vivek?
I think that's it.
Abhishek, anything?
One thing, always remember that if not, it's always next year, really. Come with that approach. One of the highest scoring trainees from my year actually basically did not get a job the year before. And only about 6 months later, he managed to be in the top 10. So just take it as another experience and don't give up, just try again.
Yeah, completely agree. Focus on MSRA or whichever area where you were lagging behind, complete the audit loop, go to the radiology courses like Red Dot, which will be helpful for your clinical jobs as well. And then go to the conference like ECR or British conference or RSNA, which is all online. Try to attend the sessions regarding the topics which we raised. For example, I go to the session. If similar questions are asked, you can say, you can use the conference example as well. That shows that you are motivated. So just tailor your answers. And more importantly, record your answers, reflect on it, just see how you're coming across. You will be fine. All the best.
Thank you, Bar and Abhishek. Rima, any final words?
I think just similar to what everyone said, don't give up. For me, it was on my second try that I got into radiology, and I think, you know, even if it can be a bit discouraging not to get in the first time, just use that as motivation to drive you forward, because if ultimately you know you want to do radiology, nothing should stop you. You can always find ways to improve your portfolio. There's always a little bit extra that you can do to show that you really, really want to be there.
Brilliant. Thank you very much. Just to echo what everyone has already said, like already proven, it is certainly possible to get into radiology. Each one has a very motivational and inspiring story behind how they got into radiology. So feel free to ask anyone, look into the experiences. Some people have written up their experiences on the Facebook group, go through them. That's very useful. This year and last year, especially this year, it's been really easy for people to get in. So everyone should ideally aim for to get into any competitive specialty. There is no restriction anymore, especially with RLMT taken out. When I applied, and it was very high competition, so I was very limited to where I could apply. I could apply only in Madinri, so I had 1 in 35 chance of getting a post. So those things are gone now. You can apply anywhere. You are nationally eligible, and you don't even have to wait for round 2. There is no round 2, but you don't have to be in a training scheme or anything like that. You can just apply to any specialty, be it radiology, be it surgery, be it anything else. So you should be applying and putting in the efforts, and the playing field is now leveled. So you should get into it. All right. So everyone, all the very best for. All the very best for the MSRA results on Monday. I hope everyone gets through. And
hi, can I come in for a moment, please?
Sorry, who is speaking, please?
Hi, this is Anil, one of the participants on your group. I just thought I should really thank you for this fantastic program. Really, thank you so much, Bar. Thank you very much, Abhishek, Rima, Vivek, and Mariam. Mariam, you should not undermine your achievement. Really, you have a magic wand in your hand. So if you could get in, well, that's a very modest answer, yeah. But thank you very much, all of you, including Taimur. Everybody took out time for us, came in, and having shared all your valuable experiences. Yeah, I really thank you all, guys. Thank you very much.
Thank you, Anil, for the feedback. All right. So without, unless anyone has any burning questions, let's wrap this up. Thank you again, everyone, for attending this. We'll try and provide the recording so that everyone can go through this presentation again. Please remember to fill in the feedback forms that we'll post a link later on, either tonight or tomorrow. So have a nice weekend. Thank you.